Today we will speak about scaling up OB projects by looking at one project in particular, the Uganda Health Project, how the team internalized the key lessons of the pilot, leveraged additional resources, and introduced innovative concepts in order to further expand access to a set of basic services for the poor. Our speaker today is Peter Okwera, Senior Health Specialist based in Uganda Country Office, Kampala. He is the task team leader for the Uganda Health Nutrition and Population Portfolio and supports other HNP projects in the region. Peter joined the World Bank in 1999. He holds a master's in health services management from Heidelberg University and in health economics from Curtin University. Peter will share his insights and experience on scaling up OBA projects, including a project overview, a closer look at the outputs of the project, as well as challenges and lessons learned. We have reserved time for Q&A after the presentation, but feel free to type your questions as we go along. Peter, you have the floor. Peter, could you unmute your microphone?
Okay, yeah, okay. Thank you so much, Inga. I also want to thank the rest of the organizers behind the webinar, and particularly all the rest of the participants who have taken their time to join us in our first webinar today. In this presentation, I'm going to share with you the experience that we have had in Uganda in trying to use vouchers in the provision of health services. I'll start by quickly sharing the project overview, then look at some of the key outputs from the project, and focus more on really trying to discuss the lessons that were generated, and finally end up with the challenges. The Uganda Reproductive Health Voucher Program, which was started in 2008, was started as a partnership between the GPOBA together with KFW and the World Bank and the Ministry of Health in Uganda. The idea was mainly to build on the earlier voucher scheme which KFW had funded through the Mary Stopes International. And the intention this time was to expand mainly services for safe delivery, but also build on the earlier voucher program that had been targeted towards addressing the problem of sexually transmitted diseases. In the project, the plan at the time was to use both government and private providers, but in the end, we ended up contracting only private providers. In total, about 120 of them were contracted during the project lifespan. The total funding for the project came to about 6.8. Some of this was contributed by GPOBA, and part of it came from KFW. The cost for KFW were directed more towards the running cost of the voucher management agency, and then the other cost from GPOBA really went to meet the cost for the subsidies. The voucher management agency for this particular project was Mary Stopes International, which is a UK-based NGO, mainly focused on providing reproductive health services in several countries. And the independent verification agent was PricewaterhouseCoopers. I think PwC is known to many of us. They provide a number of services, mainly financial, but they also do a number of other consultancy works. So essentially, they are the ones who are responsible for undertaking verification under the project. And lastly, KFW served both as a co-funder together with GPOBA and also as the fiduciary agent. In that, financing from the project from the bank was channeled through KFW to Mary Stopes International. So in terms of the service package, and this is I think what is most important, that the project was largely designed to focus on two packages. One package was the provision of safe delivery services, and the second package was towards the provision of care and services for the management of sexually transmitted diseases. I'll try to focus more on the safe delivery services because in the end, this is the package that we decided that we needed to scale up. And the benefits which accrued to the mothers was that a mother who was able to procure, to buy a voucher, and the vouchers were sold at 3,000 Uganda shillings is equivalent to about 1.3, 1.4 US dollars, would qualify then to receive the full range of services in terms of up to 4 antenatal care visits. They also would qualify to get what in medical terms would call basic and emergency obstetric care. By this, what we mean is that a mother would get the full range of services that are required during delivery. And in the event that the pregnancy or the delivery at that material time had a complication and became an emergency, a mother would still receive the necessary management depending on the particular emergency. And in addition to that, they would also be given support by way of transporting them from wherever they are to the facility where the emergency can be handled. And lastly, the mothers will also be able to get support for postnatal care, which will be given to the children. This project, right from the very beginning, was meant to target about 50,000 mothers, in total about 50,000 deliveries. And this was contracted on the basis that they would have the contracted cost of the deliveries would be about 70 US dollars. The recipients were mainly rural women, and the basis on which they were selected was that there were two criteria for selection. On one side, we used a means testing approach where a poverty grading tool was used. On the other hand, too, we also used the geographical targeting in places where poverty was seen to be high, and in such places where the poverty was high, then in that case, every pregnant woman would be eligible, so long as she was willing to buy the voucher. The vouchers were distributed by community-based distributors, trained by MSI, and they lived in the same communities, and they'll be responsible for moving from house to house and providing the vouchers to interested mothers. Quickly, I'll talk about really the key outputs of this project. In terms of deliveries, while the project was meant to have supported up to 50,000 deliveries, the project met and surpassed the target by an additional 30%. Over 65,000 babies were delivered under the project. For the second arm of the project, that is the STD arm, the project also was able to reach up to 31,000 clients, in total about 90% of the target. We did look at the costs finally to try to estimate the actual costs, and we did find that for a normal safe delivery, in terms of what was reimbursed to the service providers, the average cost, weighted average cost, that is for the different facilities, came to about 49. US dollars. A normal delivery was about 25, and for a complicated delivery, it was about 79. For STIs, the costs were roughly about 11 US dollars. I think I now want to turn to really the main subject of today, which is what did we learn and the processes that we went through and some of the challenges, because I think this is really where what was most important in helping us in moving forward this agenda. I think it's really important to know when a project is successful, because if you are not certain that a project is successful, if you are not certain and if you do not know whether your project is successful, you run the risk either of starting to talk too early, or you run a risk of not coming in time. And I think that was a key problem for us. Both KFW, even the ministry, and as we are quite not sure whether we are successful. And I remember it was difficult in the very beginning, even up to the time we had the midterm review, to start engaging with the ministry and with the other partners that we really think we have a successful thing. So it is important to know this. One of excuse me, I think somebody interrupted me here. I think one of the critical things that we did eventually realize, and the time when we started moving, was because we had an evaluation which was part of the program. And the findings of the evaluation really show that this project was successful. And the three key things which came out and and they stood out clearly, both in terms of while we had the increased numbers of deliveries, the increased utilization. I think we were all quite taken by surprise when we looked at the impact evaluation findings, in the sense that one, we were targeting mainly poor people compared to the richer quintiles. When we looked at uh, we did household surveys within the communities. We realized that many of the mothers were no longer delivering at home. In fact, the majority were delivering in facilities. And when this was compared between the villages where the scheme was running and the villages where the scheme was not running, the effect was the impact was so obvious. The project was having a significant impact in the communities where the voucher scheme was being implemented. Lastly, and more importantly, was the significant reduction in the likelihood to pay out-of-pocket expenditures for deliveries among these communities. All this, I think, moved us to a point where we started saying, no, we needed to do something because we were having a successful project with us. The other second thing then, which I think again we did see, was when all this was evolving, we also realized an increasing interest, not only from government, but also from the other partners. DFID and USAID had now partnered and had come up with a family planning voucher scheme, for which they needed both support of the voucher management agency as well as the bank. And with that project was eventually launched in 2010. It is now running. USAID, seeing the successes, also said, no, we need to see how to sustain some of these activities in the meantime, and decided to put additional financing in support of 4 project districts. And then lastly, SIDA, Sweden, provided 13.3 million to support the scale-up. So as we speak now, we have finalized the preparation of this project. This project will be approved any moment by the bank, and once it's approved, we should expect to move. In addition to this, the US government intends to commit an additional 25 million to support the scale-up of the same scheme in another part of the country. So what are some of the lessons that we have really seen? I think the first lesson is having a good communication and dissemination strategy. This, we are quite happy that we had a very good voucher management agency. We who had a good communication strategy. So the second thing then which we did was building on the communication strategy to work out measures for disseminating the evaluation findings. This was not only intended to talk more about the program, but also then help the key stakeholders to appreciate what worked in the project, where we met challenges, but also to interest them, especially for those who wanted to know what the project had achieved. So that was one. Two, I think, and this was very important. In Uganda, we also have other partners who are running different forms of performance-based programs, RBFs, PBFs. And what we did realize right from the very beginning when we started now communicating was that we would not start any discussions which would either infer that we are undermining one form of program or the other. Our interest was to talk about what we had done, what the project had achieved, share the lessons, share the experience, and not necessarily get embroiled in the discussions about all the different results-based financing mechanisms and approaches, because that would not have taken us far. But more importantly, when you work in the field, it's always really important to realize that people know when a project is successful, especially the local people in the districts, those in the Ministry of Health who engage in this project, and even the development partners who support projects in that support programs in that area. So in Uganda's case, we are quite lucky that once this project became successful, different people started talking about it, not only local leaders. Different providers really did talk about it. And it was really on the basis of that they now started talking to the ministry, talking to the rest of the people, saying that, okay, but there's a successful project here which is due to end. Why should we allow it to end? Two, ensuring the buy-in of development partners, including the World Bank. This looks it looks easy once you have when you're trying to talk to when we think even of the bank. But for the bank, what we really did was to involve the country director, to take him to see what was taking place in the field. For most of the development partners, we asked Mary Stops International to actually invite them and take them to see what was happening in the field, to meet the providers and to talk to the community members. We also did encourage MSI to support DFID, work with USAID in developing the other voucher programs. Essentially, this was to make sure that we are not trying to carve a program for ourselves, but we are looking at vouchers as an instrument that could be used to provide and to scale up services within the health field. And lastly, in the design of the program, we did realize that different parties, particularly development partners, would come at different times. So in the discussions with the Ministry of Health, room was provided to ensure that partners who want to join the scheme can still join the scheme at one time, so that it will not be tied to one particular project, but that the ministry look at this as a program and create structures and mechanisms in place that accommodate the coming of different partners. In doing this, agreement was reached on what the package should be, which services would be included, the cost of the cost to the mothers for buying the vouchers, how issues to do with pricing and contracting service providers would be done, and this aspect where many of these discussions took place in the open, led by the ministry, I think was very useful in getting the buy-in of the development partners, in ensuring that they see this program not as a World Bank program, but as something which is really implemented by government and where government is actually providing the leadership and that everybody is given room and given place within the table. There is one problem which I think is quite common with many of this result-based financing. And these problems relate to management costs, not only for running the program, but for verification. These costs they actually are high, and many times they are perceived to be high. And in our case, it was at about 30% of the cost. We did not run away from that fact. We acknowledge that, okay, this was a small pilot program which we had started. And in such a situation where you're really coming from scratch and you're trying to build up a robust program, these costs are bound to be high. So being transparent about management costs is crucial. But on the other hand, I think while many people in the beginning talked about the perception that these costs are quite high, it was also not possible for any other program to come up with any of the other costs. And I think this is always the dilemma of trying to talk about management costs in a situation where actually for most programs, these costs are not available. So we decided that, okay, fine, these costs are high, but we also don't know the cost of the others for the other programs. But in our case, we are focusing on our results, and I think our results were able to speak for themselves. The fourth, and particularly the most important one, I think this was where we did see the breakthrough. Once government had got the buy-in, the new minister went to the project area, the PS went to the project area, and now different partners who were going to the government, sharing and trying to find out what government could possibly do, what they could possibly do in terms of supporting. This is really where we were quite taken by surprise when government started now directly selling the program to some of the partners. And a case in point is that the funding which came from CEDA was largely after um, the ambassador had met the Minister of Health and had said, okay, we have funding and we are looking for a program to fund. And the PS and the minister said, fine, we have a successful program here. So the CEDA team came to the bank and said, we have been told that you have a successful program. We agreed with them that, okay, fine, we have a program, you can go and see. And they went to see. Two, government also then started engaging the US government in this. And this is when the need for a steering committee was established. The need for a steering committee was realized, and this committee was then put in place. And this committee brought in the key parties, both development partners, Ministry of Health, as well as providers, and essentially to share this information, to see how we can work together and build a viable program. Last, and I think this is important, at least in Uganda's case, the public service providers. You know, in Uganda's case, in the beginning, these providers were not included. Now, many of them, while they were not included, did actually see and come to realize the successes of this program because they were either in those communities or close to working in communities or districts close by to where the project was being implemented. When they did come to appreciate this, in fact, 6 of the district leaders together with the district health officers came to the bank and also went to the ministry to register their interest that they needed to join this, to join a similar scheme of a similar nature in future if one was to be there. And they started putting pressure on the ministry of the need that public providers should be involved and included in any scheme like that. And because of their interest, together with Mary Stops, what we decided then to do was to quickly undertake a study to see how we could involve public providers in such a scheme. And the findings of that report eventually was used in the development of the new project that I did allude to before, which is currently underway. So the new program not only involves the private sector, but also includes the public service providers. Uh, the importance of making sure that you mainstream this within the key government documents. I think within the Ministry of Health now, uh, the results-based financing is clearly indicated. The need to mainstream this and scale them up is being discussed. Even yesterday we had a workshop on this. So it is important to ensure that this is done. And then a critical aspect which we did do was to train stakeholders in results-based financing. A number of planners in the Ministry of Health and also officers that support the health sector in the Ministry of Finance have undergone training in this, and they have become the key champions when it comes to really pushing the agenda for results-based financing, OBA, within the government. My last comment relates to the role of the voucher management agency. I do not think we would have managed to scale this up if we did not have a credible and strong voucher management agency, particularly in terms of systems for claims processing, ability to share their findings and provide support to interested parties that they were willing to share to tech partners, but more importantly, to come out to manage the other programs and to manage them well. I think the manner in which they did this, their professionalism, their competence, was a big attribute which today explains part of the successes that we have had. Now, lastly, I'll just talk briefly about the challenges because these are broad challenges. The first challenge that we really did meet in the beginning was that of the diverse interest of the development partners. Most partners come with their different views. We had DFID was interested only in family planning. USAID needed PMTCT, prevention of mother-to-child transmission, because they were looking at it from the HIV/AIDS angle. Even within the bank, there were those who were wondering whether we should be focusing still on reproductive health or we should be expanding services. So managing those diverse interests was a challenge. Our ability to do this and to still retain the focus on really reproductive health was largely because of the commitment in the Ministry of Health, first and foremost, that there is general agreement that that is an area where support needs to be. And also the fact that within the broader country, and particularly in the media, issues of reproductive health are quite paramount. So with that, we were able to get a sense that we need to still focus and build from there. It's always true that partners are particularly suspicious of the World Bank. I remember several partners asking me directly that why is the bank interested in this? We don't, the money is not much, it's just a grant. So why is the bank spending so much time trying to scale up reproductive health services in the country through a voucher scheme? I think for many of them, they thought we had some other motive. We were not really not in this for a particular purpose, but we clearly told them that if you look at government documents, if you look at the bank itself, the bank is concerned about the high maternal mortality rate in this country, and this is an area where the bank has chosen to work. But more importantly, the Minister of Finance, the government themselves were interested that they want to be moving more towards results-based financing. And they were looking at the project which had been successful as one way of scaling that up. The unfortunate part is still the unhealthy competition, which persists even as I speak today. Semantics, we still do have semantics, we still do have territorial behavior among different partners. We still have people who say, okay, the only way is this type of PBF, this type of performance-based contracting, this type of RBF. And so we have a number of such challenges in the country. the view that we have taken, because this was discussed yesterday, is that first and foremost, what we really need in Uganda, we need to be very clear in terms of principles that will underlie any results-based financing. And also, and these principles will relate to how we define our outputs, the process for verification, and 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 then the the purchasing arrangements. And I think those are the critical things. We realize we'll need to strengthen systems, do a number of other activities to build the institutional capacity. But foremost, it's important to be clear that there needs to be very there it's important that with government and the partners we reach agreement on the key parameters, and this is work which is currently still going on in terms of reaching consensus, particularly in those areas. Finally, concerns for sustainability remain. We discuss this matter constantly, and I think it's an issue that will always persist if you work in a country like Uganda, where uh, obviously, for obvious reasons, the government and the country is challenged with resources. So there will still be need to mobilize resources. And to me, as a person, and this is what I always say, that when we think about any of these new approaches we are using for whether it's OBA, any of the results-based financing, we are really focusing on strengthening our purchasing capacity, that we want to make sure that the government is buying the best services and it knows the type of service it's buying. And to me, once we are clear about that, then we need to work with government to ensure that even the current resources that they have, they should see to they should see ways of making sure that these resources are channeled in such a manner that this, in the end, they are buying resources they are buying services really in a manner that helps them get value for money. So, Inga, I think I want to thank you, and I will respond to the questions with time. Thank you so much.
Peter, thank you very
Yes,
much.
please.
This was a very interesting presentation. We received quite a few questions in the chat, and we will be going through them. In the meantime, Leslie David, our colleague from GPOBA who worked on the project, has been responding on some questions, especially those that pertain to the project, which is perfect because now we can focus on the other questions pertaining to scale up. I have the first question for you, Peter, and it comes from George Gotadze from Georgia, and he's asking, what was the rationale for selling vouchers instead of free distribution, especially for those cases where objective was to reach poorer women identified through means test? And how did that affect the establishment of the voucher unit cost? So if you can take that first question, Peter.
Yeah, thank you, Inga. This is an important question, and this partly explains why, in the very beginning, we could not get public providers to join the scheme. But what did happen before we actually set the prices for the vouchers was that MSI did, together with the Ministry of Health, undertake a study, a willingness to pay study, to try to determine the cost that an ordinary woman in the village would be willing to pay for them to access services. No, it is important to realize that even when we say that services are free in public facilities, that they are not really free in the real sense, because the mothers have to buy other supplies, including gloves, the drugs, and the medications that they need to that they'll need for during the pregnancy. So when you factor on all this, then the services are not really free. The mothers pay. Now, for many mothers, once it had been explained to them that, you see, with the payment of about 1.5 US dollars, you'd be entitled to receive care without having to incur an additional cost. You don't have to buy gloves, you don't have to buy syringes, you don't have to buy any other medication at all. All you need to do is present yourself. So this is the basis on which this was done. We also did institute another study to look at the costs so as to be able to determine the unit cost for contracting the service providers. This was undertaken on behalf of the voucher management agency by an independent consultant. And on the basis of those costs, the VMA and the Ministry of Health then negotiated with the providers and reached an understanding for services at different levels for the smaller facilities like small health centers, which are ambulatory centers, and then for hospitals. And this is how the actual costs were reached at. I hope that is able to handle, yeah, George, I think we have addressed that.
Yes, Peter, you did. You actually also addressed the second question that I was going to ask, and it came from Miriam. It is true that even in countries where health services, basic health services are free, women find themselves in the situation of having to buy the service or part of the service or utensils and other things on the market in order to uh, avail themselves of a better quality of service. Um, so there's another question for you, and that is again on scale up. And the question again comes from George, and he's asking if the scale up phase is expected to include public service providers, assume that they are funded directly out of the state or local budget. How would voucher-based provider payments, that is output-based payments, would be reconciled with the budget financing? And this again goes back to the question of scale up, what you've been doing in Uganda, and trying to mainstream the approach into public service provisions. So if you can address that, thank you.
Okay, yeah, thank you, Inga. Again, this is another interesting case and question, and it's one of those that I've had to answer several times. Um, I, my normal answer, my usual answer is to say, even in the other countries which are currently involved in RBF programs, they include both public and private facilities. And in Uganda's case, you do realize that the financing approach may be different, but even for what we call the faith-based, the church-based facilities, they do receive subventions from government. So there's still an element of government funding or some public funding coming from some church organization or some group of people who particularly finance the church facilities. Now, what has been done is, and this is the costing study that I did talk about, what the program and what the ministry and previously the voucher management agency in getting this consultant was to first understand the financing and cost structures of these facilities, how much money they are getting from different sources, and how much money they, so that they are able to try to decompose these costs and try to see then if you are going to provide this service, what additional cost, what additional financing do you need, and how do we cost that and make sure that when we pay you for a service, this is what we'll do. So this is essentially what was done. So in Uganda's case, when it comes to reimbursing public providers, they will not be reimbursed at the same rate as a private provider. Essentially because we all know that they do receive much more funding from government. Likewise, when it comes to reimbursing a church-based facility, they will not be reimbursed at the same level one would reimburse a fully private facility that uh, relies more or less entirely on financing from patients or from in some cases health insurance in the country. So the rates, the reimbursement rates for the different categories of providers will vary depending on their actual resource base, whether from government or from other sources, as in the case of the church-based facilities.
Thank you, Peter. So when you say that rates will vary depending on the service
Yes,
provider, at the same time, the package of services that women would buy will stay the same. It will be the same quality of services, the same list of services. Um, that's my understanding. And then the question is uh, how how different are the costs, the transaction and supervision costs from the pilot to the scale-up project? Do you expect those to go up, down, and how will this be absorbed by the cost of the service of the vouchers?
oh yeah, no, I think that is going to depend on a number of factors. First, you'll have facilities that have graduated. They know how to submit claims. They know they have clear expectations about the program, and they have put in their own systems to work with the program. So where, like for instance, the project was executed before, we should expect very little challenges in terms of the next steps, because essentially they already have systems in place. Now, when we choose to go to new areas, which is going to happen, they have not heard about a voucher before. This is the first time we are obviously selling. So costs in such places will initially be high. We also expect that the cost, particularly for public providers, will be much higher for helping them start, and also supervising and supporting them in the immediate term. And for this, the Ministry of Health has is putting in place a team. They currently have an officer who has been recruited and dedicated specifically to support our public providers, to ensure that their concerns, their needs are addressed, and this is being factored into the operations manual, which is currently being revised. Uh, More importantly, because public providers in Uganda do not know and in fact, do not have to prepare and submit claims. One of the things which will be done is to make sure that they are trained by the VMA, they are given the necessary support so that they can actually prepare and submit these claims in a timely manner. So those aspects are really critical. But I think we'll reach a point when, depending on the level of coverage, when the cost will no longer be going up given the economies of scale. But I think in the immediate term, we shall be seeing that particularly the cost of expanding the program and establishing it in new places will, will still partly drive some of the overhead costs. But we do expect that with time that should eventually cease.
Thank you, Peter. The other question, it's related to cost, it's related to demand. Um, you said that you've done a lot of work, the project, stakeholders involved have done a lot of work to stimulate the demand and change in behavior among expecting mothers to attend the clinics. Um, any advice, any lessons learned from there, and how to move on forward with the scale up to boost that demand? And as you move on to new geographic territories, um, what techniques are you using to advertise and to stimulate the demand among expecting mothers for this kind of service?
Okay. This is an area where you need a good voucher management agency, because that is really the interface between that is the critical interface between the project and and the communities, because you need the mothers to eventually to be going for services. And the issue of really continuing to support behavioral communication change, BCC activities, continuing to market the services is an area which I think as a project we will continue giving due emphasis. It is too early to say, but we are still hopeful that we are going to end up with the same voucher management agency as before. We are in the final stages of contracting the management agency, and among the things we look at critically, and that is what the among in the selection process is ability and competence in doing good marketing as well as communicating with the local population in this respect. So that those activities geared towards promoting and encouraging mothers will continue under the scheme.
And that is a very important activity, a very important component of the of the pilot before now of the scale-up activity. Well, thank you, Peter, very much for your presentation and for answering the questions of the participants. Those who are still online, you can still type your questions. We will make sure that they are answered even post webinar. I would like to thank everyone for participation and for your attendance. The webinar materials will be placed on our gpoba.org/webinar website, and there you will find the presentation, the Adobe Connect recording of the session, and also there you'll be able to continue the discussion after we close the webinar today. Just as a reminder, this is the first of a series of webinars that GPOBA is broadcasting. Please stay tuned for the next one, which will be dedicated to urban transport at the end of April. Additional information will be sent to you as we approach the date. Thank you very much again for your participation. And please complete the survey of the webinar. We will take your suggestions seriously to improve the next ones.